Okay. Good afternoon, everyone. I hope everyone's awake after lunch. Thank you so much for joining our session in Equity in Research Sampling. I'm Catherine Birken. I'm a pediatrician here and researcher, and really excited to be part of the Edwin S.H. Leong Center. I'm one of the chairs in Child Health Intervention, and I'm really excited to share with you this session. We have three wonderful speakers, and what we're going to do is we're going to give each of them 10 minutes to speak, and then an opportunity to answer some of your questions for about 5 minutes. And then all three speakers will come to the front for about 20 minutes of an opportunity to ask them questions and have a really fulfilling conversation. We had a really amazing session this morning, so I'm sure we will not disappoint this afternoon. So I'm going to start by introducing Lawrence Mbuagbaw, who is an associate professor at McMaster University, where he teaches courses in biostatistics and randomized controlled trials. He's also an associate professor of epidemiology and biostatistics at Stellenbosch University and research method scientist at the Research Institute of St. Joseph's Hospital in Hamilton, where he provides methodological and statistical support for many researchers as the director of biostatistics. Dr. Mbuagbaw's presentation will focus on the utilization of an equity framework to augment research sampling in both randomized controlled trials and observational studies. Please, Lawrence, come on up. Thank you, Zudi, for keeping us on track.
Thanks so much for the introduction, Catherine. So I will head right into it, and I'm going to talk essentially about these three things. So we'll look at what the problem is with regards to equity in sampling, and I'll talk about some of the frameworks that we can use to prevent inequities in sampling and improving the diversity of our samples. And then I'll show some examples of things that have been done and talk about some of the things that you can do in your own research for to improve equity and diversity. So the Dictionary of Epidemiology defines sampling as the process of selecting a number of subjects from all the subjects in a particular group or universe. And the idea here is that your sample doesn't include everybody that you would like to do research on, but you can't do research on everybody for a number of reasons. The first is that usually the target population, the people for whom you want to make inferences, is just too large, right? The target population is too large. So you need few of them. And research and science and the central limit theorem have shown that it is sufficient to study a subset of the population to get a correct answer. You can do this most of the time, right? And also, of course, everybody has a finite budget and finite time. You want to complete your research before your program ends. And there are also ethical reasons why you need a sample, so that in the case of a randomized trial, you don't expose people unduly to harm. You do research in a few people and then extrapolate those findings to a larger sample, right? And then, of course, there are also scientific reasons why you would use a sample, so that you can try to establish some sort of internal validity and external validity when your sample is the same as your target population. So the general idea of implementing research is that your target population, the people you want to make inferences about, is the same as your research sample, right? And usually, if you have a sufficiently large, simple random sample, your research sample will resemble your target population. But what happens most of the time is our samples are not random, right? Most people don't do random samples, because to do this, you need a sampling frame. A sampling frame is a list of all the people. If you're doing research on Canadians, you need a list of all the Canadians, and then you randomly select from that list, right? So almost nobody does simple random samples. And even people who may have the resources to do random samples may not end up with sample sizes that are large enough, right? Most sample sizes are just too small to be representative. And even large sample sizes may not always be as diverse as we want them, right? They may miss out some of the vulnerable groups who, for one reason or the other, are disinclined to participate or be included in research, either because of their language, either because of transportation issues or childcare issues, or income issues, you name it. And this happens sometimes because researchers do not have the knowledge about issues around sampling and external validity and generalizability and how to reach out to these populations, or they don't have the time or the money to do an appropriately diverse sample, or sometimes they just don't have the access to those populations, right? You need an into a population that you're trying to study. If it's a vulnerable population, say of men who have sex with men, or transgender people, or indigenous people, if you don't have champions in that community, it's going to be challenging for you to access them, to include them in your research. So we end up with a huge problem, right? The first part of this problem is that your target population does not resemble your research sample, right? So you're doing research and making inferences for a fictitious population that doesn't really exist. And even when people have large samples, sometimes they do not collect the important data that helps them to determine if their target population resembles their research sample, right? For the longest time, Canada has not been collecting ethnicity data. So it's only during the COVID pandemic that we realized there are issues with ethnic minorities, and now we need to start collecting this data, right? But if you look at another country like the US, they have been collecting ethnic data for the longest time, right? So that's also an issue. And the endpoint is that there are large bodies of evidence that inform policy and practice based on biased research conducted on subsamples of the population. One very important example of this is that most of medicine was studied on male cadavers, right? So the old biology and medical textbooks were based on inferences from male bodies, and they tried to use that science to inform treatments in women and children, and that was just inappropriate, right? So that's just an example. And in recent years, we've seen examples of research not including people who need it the most with regards to COVID, breast cancer, heart failure, HIV, neurology, you name it. There are many examples in the literature. So one framework which you can use is the Progress Plus framework. Progress is an acronym for place of residence, race, occupation, gender, religion, education, socioeconomic status, social capital, and other contextual factors such as disability, living in residential care, or living in a shelter, for example, that may put you at a disadvantage for health outcomes, right? So the goal of the Progress Plus framework is for public health researchers to reflect on whether the way their research questions are asked or the way their data is analyzed captures all of these potential factors that could lead to inequities, right? So as a researcher who is designing research, the first thing you have to ask yourself is whether your target population includes people who may experience disadvantage based on any of these characteristics. So not all of them will be relevant to your research, but some of them would be. And this list covers many of the key issues, right? And then if that is the case, then you ask yourself, how do I design my research to include them, right? If there are people who are experiencing a disadvantage based on, say, immunization coverage, what are you going to do to reach those people? And then the next thing you need to think about is, if you're making efforts to reach those people, what are you doing in order not to aggravate this disadvantage, right? For example, people who live further away or people from low income settings would need support for transportation, they might need support for childcare, they might need additional translation of documents if they're from low levels of education, and you need to accommodate that so that you're not aggravating inequities by trying to include them in your research. I'll also like you to bear in mind that all these factors do not exist in vacuums, that they sort of interact, right? The same person who has an occupation that puts them at high risk for respiratory tract infections may also have a low level of education and may come from an ethnic minority, right? So all of these interact and they need to be considered holistically. The next framework, which came out of the UK, is the Include Ethnicity framework. It's designed mostly for randomized control trials. And they have 4 questions which you should ask yourself in sequence if you're designing trial and you want to be inclusive of ethnic minorities. The first is, who should my trial results apply to? if you're planning for your trial results to apply to everybody in Canada, and then the people in your trial should reflect the diversity of Canada, right? If you have a trial which includes only white people or only Black people or only Indigenous people, and then you're not really answering that question. Then you ask yourself, are the groups identified in question 1 likely to respond to the treatment in different ways, right? Based on the intervention, there might be reasons why there may be biological differences or social differences in people's responses. And then you should also ask yourself if your intervention or comparator will make it harder for the identified groups to engage with the intervention or comparator, right? It could be an intervention which involves text messaging or people using computers or something like that. And people who are at low income or people who are living in remote areas where they don't have a good signal will have difficulties in engaging with this research. And then you should also ask yourself, will the way I have planned and designed my trial make it harder for any of the groups identified in question 1 to consider taking part, right? This is a key issue which I find with a lot of research when they say, oh, recruited from 9 to 5. So it means, well, if you are looking for healthy, normal working people, none of them will be in your study because you're recruiting while people are at work, right? So they will automatically be excluded, right? And if you're planning on recruiting students and you're not recruiting the summer periods when students are out of school, you're not going to get them, right? So think holistically with your design so that the people you will capture will match who your trial is going to apply to. So we set up a framework which helps to determine whether research is equity relevant, as in research that is answering broad questions versus research that is trying to answer a question about equity. And the bottom line is you can address these kinds of research questions in 2 ways. The first is by getting a mixed group of people, right? So you get, if you're looking at ethnicity, you get do a study with all the ethnicities, and then you compare the results. Or you can get men and women, and you compare results men versus women, or people of all levels of education, and then you stratify your data to see if there are any differences by level of education. The alternative scenario is to focus exclusively on the disadvantaged group, right? And the idea here is that if sufficient research has not been done in a group, and then there is no added value in looking at the contrast between that group and other groups, just do research on that group on their own, right? That's why you see with HIV research, people do research uniquely for women. They do research uniquely for ethnic minorities, or they do research uniquely for men who have sex with men, for example, or injection drug users, because these are the people who are not represented in most of the other research. So I am going to talk about the AC study, which was a cross-sectional study conducted in the GTA to look at HIV vulnerability in African, Caribbean, and Black people. The reason why this study was initiated is that Black people in Ontario are disproportionately affected by HIV. The number of Black people does not match their relative proportion or incidence of HIV in this group. And it is believed that the incidence of HIV is high in Black people because they come from countries where HIV is already high. But these people arrive here with a negative HIV status, and they acquire HIV here, which means that there is something in Canada that is putting them at an accrued risk of HIV infection, right? And it's a community recognized problem. It is recognized by the government. They are recognized as one of the priority populations for HIV control. And this study was set out to answer some of those questions, right? And in order to make this study work, we had to be heavily invested in the community. We had to get the community involved. So the principles of the study were community stewardship and leadership, diversity, capacity building, and integrated KT. So interestingly, when I say diversity, you'll say, but this is the study in Black people. What more diversity are you talking about? So we had Black Canadians, we had people who immigrated from the Caribbean, people who immigrated from Africa, Black Americans who came to Canada, and even within Africa, we had Southeastern Africa, we had Western Central Africa, and so there was that diversity which we tried to capture because there are significant sociocultural differences between these groups of people. And in order to make this study work, we went an extra mile to use specific engagement strategies. The first thing we did was to use census data to understand the distribution by age, sex, place of residence, and region of origin in the world, so that our sample would really reflect the distribution of Black people in the GTA. And then we used peer recruiters. So it was other Black people who went out to recruit more Black people with HIV. We used social networks of Black people. We went to venues that Black people frequent, like Black community health centers, like Taibu, for example. And we also went to venues that Black people frequent. And there were some churches involved, and also events that attract Black people, such as the Caribana Festival. And then we applied a sort of flexible enrollment where if you're interested in the study, that's fine. We won't bother you while you're at your party, while you're enjoying your festival. We'll call you later and schedule an interview. So people were more likely to be enrolled because we didn't ask for the data immediately, right? And then we also offered opportunities for HIV testing and care. So during the study, anybody who consented to have an HIV test would have the HIV test. If the test was positive, they were directed to care. So people had that opportunity to get care, right? And then we also did a sort of multi-level consent, in the sense that the study had 3 parts, and people were able to consent for one part and not for the others, right? Because part of the reason why many minority groups will not engage in research is that there are some parts of the research that they're not comfortable with, and which the researchers are not willing to change, right? So you lose the whole participant, as opposed to being able to, engage them in the parts that they're comfortable with and actually get the data that you want. We had questionnaires in English and in French, and we provided assistance in case people wanted somebody to actually read out the questions for them and help them answer the questions. And there was also a $40 honorarium. So the end result of this is that we got one of the largest cross-sectional studies of Black people in the GTA, with 1,380 people, right? And they were aged 15 to 64, and there was a whole lot of consideration of equity in talking about sexual and reproductive health and extending the lower limit of the age to 15, because the age of majority in Ontario is 18, right? And we said we wanted to interview kids who were aged up as low as 15. So we had pushback from funders and ethics review boards for this reason, but we came back and said, well, it will be inequitable to exclude them, because 15-year-olds are sexually active and we're asking questions about sexual health. So the moral impetus is to include them and to provide services for them if they have any concerns, if they have any questions, if any of them shows up with an HIV test. So we secured all those services and made sure that they were ready. So for scenario 2, if you're dealing with a mixed population, the first thing you have to do is to identify the equity relevant factors, right? In my research, for example, if it's research on hypertension, do you think the incidence of hypertension will be different based on ethnicity, based on income, based on religion? Probably not. Based on place of residence? Probably not. So you have to do the research and figure out what equity relevant factors you want to include in your research. And then you implement strategies to include people who have any of those characteristics, right? And some of this may include having co-investigators from those groups. I recently published a paper with a cardiologist showing that women are more likely to participate in cardiology research if the principal investigators are women. And this is true for many other disadvantaged groups, right? If none of the investigators is a Black person, I would think, well, why are white people studying me and I'm not participating in that research? I don't have to think it out loud. It just happens subconsciously if you don't identify with the researchers. So you can do the same for the research staff. You could identify community champions, people within the community who could take your message in, and also adopt flexible enrollment strategies, right? Let people join the study whenever they want and be able to leave whenever they want. Translation is important. Make sure you have your research materials in multiple languages if you intend to include people who don't only speak English. And then consider multimedia study information, so written materials, videos, and other sorts of materials, audio that people can use. Also do community engagement, right? Like go into the communities and advertise your study there. Let people know that this is what is going on and that you're interested in including people from these groups. And then you can also continue this with outreach as well, right? Going into the communities, especially with peers, to reach out to people and get them in your study. Now, if you have them in your study, make sure you collect the data on these equity relevant factors, right? And if you have it, you should report disaggregated findings. So it seems straightforward, but there are challenges. It is more resource intensive to have a truly equitable sample, right? And the added value is not obvious at the outset. When you're doing it, it looks like it's extra work, but you can definitely make a lot of impact with the kind of research you do if it's equitable. And then people will always ask the question of, I'm not powered for subgroups. Why am I collecting all this subgroup information? But the truth is the opportunities with this kind of equitable sampling is that it is more rewarding. You increase diversity, you increase equity, and your disaggregated data will inform meta-analysis in the future, right? If I'm doing a study on hypertension in women and there are no studies on hypertension with disaggregated female data, I will never be able to pull that data, right? So all we're asking is, even if there are 5 of them, report the data separately so that somebody else can use it, right? And this highlights signals for future research that can be used down the line. So take-home message is we can do more to ensure equity in research sampling, and we should include these advanced sampling approaches when we're designing the study, put in the grant proposal, and budget for it because it's expensive. It costs money to be equitable, right? Make sure you compare your research sample to your target population to make sure that they match, and work with the community, right? You're not going there to take research from them. It is their data. They choose whether they will share it with you or not. So work with the community through all of this process. And also you could use pilot studies to identify recruitment issues. In a pilot study, you can find out why people choose to participate in the study or not, and you can adapt the main study to make things work. And also peer recruiters make a difference, right? People want to see their peers in research that they are doing. So if your research is on youth, have youth involved in the recruitment process. Thank you.
Okay, we have time for one question, and then we can ask Lawrence when we sit as a group. Any questions people have? And just
I see 2.
push your microphone. If it's beeping, that means you're the next one, Laura.
Talk loud.
Okay.
Great talk. Thank you so much. What happened with the response rate? So there's great sampling, but there's also a big problem with response and uptake.
Yeah. So with studies like this, it is extremely challenging to calculate what you would call a true response rate because we advertised everywhere and to everybody.
Yeah.
Right? So we can't say who was invited and who didn't come. But we have a sense of the people who we approached. They said they will participate in the study and they never showed up.
Right.
Yeah, we have about 50 to 100 of those people. And among the 1,380, we have close to 100 who chose not to respond to specific questions. But we were perfectly fine with this because there were some questions that people will be more comfortable with than others. There were questions about experiences of racism. There were questions about sexual practices. There were questions about use of illicit substances. So when people chose not to respond to those questions, we didn't press.
I know you'll have more questions for Lawrence, but I'm going to keep us going so we make it to our last session. Thank you so much. Okay, so I'm delighted to invite Melissa McCradden, who is a bioethicist with the Department of Bioethics here at Sick Kids, and is the John and Melinda Thompson Director of Artificial Intelligence in Medicine, leading the integration arm of the AI in Medicine initiative here, and associate scientist with genetics and genome biology research here. Her research focuses on AI ethics, from a developmental and evaluation to bedside integration, with a focus on child health. Her presentation today will focus on development of institutional guidelines to address equity and fairness issues in the design, development, testing, and use of machine learning in data-driven research. So welcome, Melissa.
Perfect. Thank you. Okay, so I'm here to talk about an institutional guideline that we're developing to try and advance equity through the use of AI at SickKids. And so just to start, when I'm talking about AI, what I'm referring to is a computer-based system that is at the bedside that can compute incoming patient data and collate it in a way to give a prediction to a clinician who's at the bedside. The predictions can be anything from a diagnosis to a risk score to a category, and they're used to help clinicians make decisions. AI is advanced through the use of machine learning, which is a branch of methodologies that are pertaining to developing algorithms. And so what's really important about that is that they work off of patterns. So we can make diagnoses, for example, based on patterns that are apparent, and that's basically how AI works. It looks at these patterns and produces meaningful ways of representing those to the clinician. So one of the things that we know about AI is that because it operates off of patterns, it doesn't always know what is relevant to something medical versus what is being influenced by other factors like societal inequity. And so I always start with talking about the consequences because that's really why we're here. This is an example of a paper that came out in 2019 where they looked at the use of a commonly used algorithm in the United States to allocate patients into a beneficial complex care management program. And so what they found, what the researchers found once they got a hold of the algorithm is that it was the way that it was making predictions. Patients who are Black were twice as sick as patients who are white at the point when they were referred into this care program. So what's really important about this is that the researchers who developed the tool, they realized that there would be inequities, and so they actually removed patient race from the calculus to make these predictions. However, because we're talking about patterns, the patterns are still apparent in the data, and so we still had this biased output. So it really calls us to the principle of humility in thinking about what we do and do not know about these systems and taking a deliberate and values-based approach to how we actually use them and develop them. So algorithmic bias is essentially the problem that underpins the issue that I just spoke about. And algorithmic bias is the extant influence of factors on these algorithmic predictions. So in the example I just listed, one of the reasons that that bias was present was because the algorithm was designed to look at how much money is spent on individual patients and to use that as a proxy for medical need. So because we spend less money caring for Black patients than we do white patients, those patterns were apparent in that algorithm. So ideally, this sort of algorithm would have been just predicting health need. What is the burden on this patient? How sick are they? How many times do they need to go and seek care for an urgent medical problem? But you get these larger patterns of insurance and access to healthcare and inequities in the prevalence of the problems themselves. So a lot of extra stuff actually gets in here when we're trying to just do a medical prediction. So some of these things are modifiable and some of them are not because they map onto our larger society. My colleagues did this really nice paper where they talk about all of the different ways that bias actually enters into the development of an AI model. And so sometimes people think, well, we just need more data from representative groups and then we'll be okay. But it's actually not the case because even though we might include more people from different groups, we're still modeling the patterns that those folks live with. And so we're not necessarily correcting issues simply by increasing representation. One of the ways that this comes about is problem selection. So throughout the world, the problems that are studied that get more funding are influenced by different factors. So we heard earlier about studying cardiac problems. So for a long time, that was only done in males. So we had different knowledge about that. Throughout the world, we have different levels of funding for CSF versus sickle cell, for example. This then influences our data collection practices. So we might have more data available to better understand certain medical problems. And so this can exacerbate the data that we have to work with to try and understand how we can use that data to make a prediction. With outcome definition, we know that the labels that we assign to patients are not simply due to medical factors. Sometimes there's prejudice, sometimes there's lack of recognition of particular problems among certain groups. And so those outcomes that we're trying to predict are not sort of pure and objective. They can be influenced in certain ways. When we actually develop an algorithm, the choices about how we use that algorithm can also introduce different risks. So if you're treating everybody the same and you're outputting a particular risk score, that might lead to different consequences versus if you had one threshold for some patients and a different threshold for others. And then post-deployment or post-integration changes talks about how when we use a model in the real world, we are actually trying to change practice because we're trying to change a health outcome. But then we need to look at how the model continues to perform. Is it actually still doing what we thought it was doing? Is it actually improving health in the way that we thought it would? And so it's clear that this problem is also in pediatrics. Sometimes we tend to think that, we're more or less subject to biases in different areas, but it's important to look at all problems that have the potential influence of bias. And really what we're trying to do, we're trying to figure out how do we use this model to model the real stuff, meaning how do we make it accurate, and then reconciling that with what we want the model to do. Because sometimes when we try and make something really accurate, we might simply be replicating the problems that are in the real world. So what do we want this model to do forces us to ask the question of what values are at play. And so that's where this guideline comes in. It's called Justice, Equity, Fairness, and Anti-Bias, or JustFab. And this guideline is an institutional guideline that is being developed to try and support researchers, clinicians, patients, and families in understanding and addressing algorithmic bias. And it goes all the way through the life cycle of AI. So how we integrate AI involves 4 steps. And so the first of these steps is design and development, where we're developing an AI system. For the JustFab guideline at this stage, the guidance supports researchers in identifying potential sources of bias, linking to the literature, and identify potential mitigation strategies. At the end of that first stage, you should have a model that has been validated on a data set. The second stage is silent trial. So you take that model and you put it into a clinical care environment, but the predictions don't actually go to the clinical team. So they're not being used to influence care. The predictions go to a research team, which then looks at what predictions are being made and looks at the true outcome of the patient to try and understand, first of all, whether the model is doing what we thought it was doing. And second, what are the health outcomes that are going to be affected by the model? At that stage, the JustFab guideline can help us identify how the model is performing in different subgroups, what potential risks there might be, and allows us to explore potential mitigation strategies in that real-world environment. In the third stage, which is prospective clinical evaluation, this is where we're actually testing the use of the model on a real patient outcome. So that's where the model is being used to influence patient care and involves traditional research methods like an observational trial or an interventional trial. Once it's past that, it's proven to be beneficial, we move to the fourth stage, which is monitoring and oversight. So making sure that the algorithm continues to perform as expected and that our outcomes are lining up with what we want them to be. And the guiding principle for this guideline is distributive justice. So distributive justice refers to characterizing and addressing the distributive benefits and burdens of a given intervention in order to promote fair treatment. And for AI, this means that we need to do 2 things. The first is that we need to empirically characterize the performance of that system. So how is it performing in terms of accuracy, error rates against different patient subgroups? The second is using that information to make a values-based decision on how we're going to implement that model. So some of the caveats to this that I always mention are labels are labels. They don't always fit perfectly. And so we want to avoid this sort of algorithmic determinism that sometimes comes up when we use computer systems. And data is precise. It's imperfectly captured, and it's almost always a proxy for larger things that we're looking at. So for example, when we might get data on sex and gender, we have to remember that that doesn't necessarily correlate to a person's hormone levels or to their body or to their identity as individuals. And AI fairness will always be meaningless without a concomitant commitment to anti-racism, anti-oppression, trans and gender diverse inclusiveness, and other affirming practices in healthcare. Once we've identified the different options, we can look at the values that we want to operationalize. So sometimes that might be awareness. A clinician might need to have accurate information at the bedside, for example, to make a prognosis estimate for a patient. In other cases, we might want to aim for equality. So we might want to make sure all patients with the same medical factors are all being referred to a given test or diagnostic service. And in other cases, we might want to advance equity. So there might be a specifically underserved group that we want to ensure gets increased access to a particular service. And how we adjudicate among these different issues requires a lot of input from those with what we would call epistemic privilege. So the idea that knowledge through lived experience is relevant to the scientific endeavor is a core practice within this model. And so we are moving at the consultation stage right now, going to different equity-seeking groups across the hospital, getting their engagement and their advice, their suggestions to really figure out how we can do the best job that we can with this guideline at Sick Kids. So thank you so much. I look forward to your questions.
Okay, can you try one more time for the button? Push the button. Hopefully the mic will work. Any questions? We have time for one question. Go ahead. Try your button. Let's just try for fun because we're being recorded, so people can. Does it work?
I think so.
Great.
It's flashing. Is that what's working?
No. Okay.
Can I do a thing here?
Maybe put. No, I don't think so. Think so? If it's flashing, he's your next. Okay. We thought we fixed it, but I guess. Do you think? Mine's not.
Yeah, I think I made yours flash.
Okay then.
I wonder if I can. It looks like I can select the mics here. So.
Wow.
Okay. That's okay. Go
There.
for it.
I got you, I think.
Got it. It's still flashing.
Yeah, this one it's 12 that's off. One of them.
Okay, no worries. That's okay. Go ahead.
Great talk, Melissa. I have a question for you. In terms of the timing to implementation, I remember I think it was in another talk that you were giving, and you were talking about the number of algorithms that have developed, the number of publications versus the amount that have actually been implemented into clinical care.
Yeah.
And there's a big disparity between those two. Do you think that this framework is going to help us? And what do you think? What do you think the ideal timeline from developing a new model to implementing clinical care looks like once you go through all the steps?
That's a good question. I think there has been a lot of enthusiasm in this field. The majority of those have not been implemented because they don't actually work. There's a fantastic paper by Deb Raji called The Fallacy of AI Functionality that actually outlines all the reasons why. And I think the primary reason is because we haven't brought thoughtfulness into how we develop algorithms. And so what I hope is that this guideline will help us bring that increased thought that will increase the relevance of the solutions that we try to create for the bedside. But I also accept that a certain amount of translation involves failure and involves, all of that. So I don't know that I could say like what an ideal timeline would necessarily be, but I think we're getting closer to setting an ideal process and an ideal set of steps that I do think will streamline implementation overall.
And do you think we're closer to understanding what's the right inputs in the training, like what the training set should actually look like and what variables should be included and which ones should be excluded? Do we have a good approach to that yet?
Yeah, I think we're able to think a little bit more carefully about that now in terms of the design steps. Like it used to be, you just take all the data and you throw it into the algorithm, right? And I think now, especially with some of these factors, we now have tests that we can run to say, is this actually relevant for this task, or is this something that we can exclude, but maybe evaluate on that factor? So if race isn't relevant for the prediction task, but we want to make sure it's working well in different racial groups, We keep it out of the algorithm, but we can evaluate whether it's working on those groups.
Thank you so much. So our final speaker is Susan Samuel, who's a professor in the Department of Pediatrics and Community Health at University of Calgary and a member of the Alberta Children's Hospital Research Institute and the O'Brien Institute for Public Health. She's a Canada Research Chair and the director of the Empowering Next Generation Researchers in Perinatal and Child Health, ENRICH, which is our now national health research training program for children. And her presentation will draw on examples from her own research program to illustrate the importance of equity in research sampling and help us think a little bit about training the next generation of researchers in child health. Welcome, Susan.
Thanks, everybody. I know it's the afternoon after lunch. Everybody's getting a little sleepy. We'll try to wrap this up very soon. And I'm going to use the mic. I didn't use it last time because I like engaging closer to the audience. So if you can't hear me, please do let me know. Okay, so I have two objectives today, is to share with you the importance of equity in trial design and conduct, highlighting one of my own studies, and then we can have a discussion about how we're embedding equity in child health research training going forward. So this is an area that's close to my heart, and the research, half of my research program is focused on transition to adult care. So we know that chronic disease is common in children, and that approximately 15 to 20% of all youth have chronic health conditions, and the majority will need a transfer to adult care. And our goal as healthcare providers and researchers in child health is to ensure a successful transition to adult care. And we know that transitions in general, and in particular transition to adult care, is a very complex time. There are multiple layers, as we heard this morning with our panel speakers. There are multiple layers to a child's life or a youth's life. So there are patient level factors, family level factors, and systemic factors that create either barriers or facilitators to transitioning into adulthood and into adult care. So as healthcare providers, we need to be very mindful that planned and careful transitions are necessary. So in child physical health care, mental health care, and youth health care, we focus on preparation for transfer by pediatric providers, where the families and the youth are very involved. And then we get them ready to go and embrace the adult healthcare system. And there's a mandatory transfer to adult care for many who are in child-centered specialty care systems. And then there's an adaptation to adult care that happens usually after the age of 18 and into emerging adulthood. So our team was very interested in Alberta to design a person-centered intervention that was informed by a large multidisciplinary group of stakeholders or partners, healthcare providers, as well as patients who ranked their preferences for interventions that should be tested. And we came up with a person-centered intervention that is access to a social worker with considerable experience who can help youth prepare for transition to adult care and to navigate the adult care systems by being a systems broker, to coach the youth in self-management skills and plan for crisis management, and also to help overcome socioeconomic barriers. So great idea. So we applied for funding to many different sources, and we accumulated enough funding to roll out the study. It is a provincial, pragmatic, randomized controlled trial from 3 pediatric hospitals, recruiting from 3 pediatric hospitals in Alberta. And that's pretty much all of Alberta. And our goal was to recruit 600 youth. And this was our pre-pandemic goal. And the stated objective is to evaluate the effectiveness of a patient navigator service. The trial had a triple aim framework. So we had both qualitative and quantitative components. We were evaluating health service outcomes, patient-centered outcomes, as well as cost. And the participants would experience the intervention for 24 months, or at least half of the recruited sample, based on this very simple randomized trial with 2 groups. And we had a very broad inclusion criteria. So anyone who's transferring to adult care, usually adult specialty care that requires change of provider, was eligible for enrollment. So anywhere from 16 to 21 years of age in Alberta. And they had to have a chronic condition. They could also have a mental health condition, and they had to be a resident of Alberta in order for us to capture the outcomes. The recruited participants came from a spectrum of different clinics across Stollery Children's Hospital and Alberta Children's Hospital and the Glenrose Rehabilitation Center in Alberta. And what we found is that, first of all, our trial ramped up recruitment, and the best recruitment was February 2020. And then in March, we died. But we did keep going, and we recruited over 330 participants, although the final publication will go into the Journal of Underpowered Research due to COVID. But I think this is one of the largest trials in transitions on a general scope. So we are very proud of that, but it was incredibly difficult to do it during COVID. But what we started noticing early on, and some of these slides that I'm showing you is not because we were unaware. This was happening as the trial was rolling, and we were trying to mitigate what was happening. So more females participated. We had very hard time recruiting gender diverse individuals. And at that time, even in the questionnaire, the questions that we answered, these were designed in 2015 and 2016. They would probably not pass muster for what is acceptable sex and gender questions in terms of the level of training that we're providing now. So we had substantial difficulty. And then what we noticed as the trial was rolling is that the predominant group is still Caucasian, and it was up to 90% at the beginning. We changed some of our recruitment strategies, and we are very proud to have a few individuals from Indigenous communities as well as other ethnic minorities in Canada. And but we still ended up with 70% Caucasians in our sample. And these are youth who are participating in the study. Most of them consented as mature minors, and their reported income, so less than $12,000 they make. Most had no personal income. But if you look at their household income, they had greater than $100,000 income in their household. And I know there are limitations to these measures, but these were from affluent families. And almost, we had such a hard time recruiting from immigrant communities. So 90% of our sample are Canadian born. So it just highlights to you reflections from having someone who just closed this trial and had been working on it for now 6 to 7 years. The randomization and recruitment introduced significant barriers. And what we ended up as a research group, even though it was at the time, we thought there was great engagement from health services stakeholders as well as patient partners. We ended up with lack of diversity in sample, loss of generalizability, and loss of power in subgroup analysis, as well as now loss of information for translation of the knowledge that we gained into policy and practice recommendations. But the intervention has been rolled out into routine care in all of Alberta, so we're very proud of that. And hopefully now that the randomization is removed, more individuals will gain access to the intervention that we're providing. There were a substantial amount of emphasis, there was a substantial emphasis put on qualitative studies throughout the whole project. So we're just mining the mountains of information that we have in qualitative form, both text-based and as well as interview information. And then I did not use the consort equity extension, which I encourage everybody to use if you're designing a trial now. But this is so valuable, and Lawrence alluded to all this earlier in his talk. So what I want to convey as someone, I'm invited here to speak about the importance of research training, and that what I want to convey is that the transformation for equity in your research and your research program really begins with you and your research team. So it's really a transformation of the mind. And that's what I gained from participating in this session and reflecting on my own trial, and then now having the privilege of running a national training program for child health research in Canada. First of all, in our own team, we need to have a good understanding of who we are studying, their attitudes, beliefs. We need to maintain standards and quality for EDI practices within our teams, within ourselves. And we need to make sure that we provide training and ensure representation and build trust amongst our own community and then to whom we're trying to reach and recruit from, and encourage diverse perspectives. And I said this earlier in the session as well. If your language in your team is going down into why it's so hard to recruit from these populations, be careful what you're saying, because those have ramifications. If these are stereotypical language, if there's microaggressions, etc., the actual participants or potential participants can sense that and they will say no. So make sure the training starts with you and then your research team. And then we spoke a lot about this in the earlier session, patient co-design or participatory research, co-design. If we had spent more time engaging youth in designing the Transition Navigator trial, we did do it quite a lot in the end, but it was a little bit too late. And COVID certainly made it even more challenging. And then prioritize equity in all the materials, every communication that you put out, you have to be mindful of that. So in the last, I think I probably take a couple more minutes to just tell you what our mandate is as a research training program. So the CIHR, which is our federal funding agency, has a strategic action plan for training, as well as mandates for health research training programs like ours, and that is to train people on different ways of knowing, including Indigenous ways of knowing, and to implement and train folks, just like you're doing here, to be at your best in terms of equity, diversity, and inclusion practices, so that the research you do benefits all Canadians, not just a few. So this is written on the Government of Canada websites. I just quoted it. So what do we do as training program leaders? We have two mandates. One is to increase representation in the researcher pool. And that is all of our goal, is to make sure that every sector of society is represented within the research workforce. And the second piece of that is to provide the training to include best practices of EDI in everything we do, right from conception to knowledge translation and implementation. And that's the challenge that we have with this training program. And you can look it up on internet, enrichyourscience.ca, if you're looking for that. So it's our new national perinatal and child health research training platform. And we have embedded equity into all domains of this. So there is emphasis on recruitment of researchers, as well as training of researchers in this learning program. And so our goal is to increase the capacity for child health research in Canada using an equitable and accessible training model. And we are providing cross-sectoral and interdisciplinary training with multidimensional mentorship. And what's really, really important, and if you were at the session that Wyatt hosted this morning, and you really listen to those panelists, the most important thing you should realize is that research is meant to improve the lives of those we are invested in, or those children that we care about. But that means that research doesn't happen in sanitized rooms like this. You have to appreciate the cross-sectoral nature of research, bringing in the patient voice, the community partners, the families, and then understanding the complexities of implementation into the solutions into the community. So this whole training program has challenged us to become cross-sectoral in our thinking. So we're not just training academic researchers, but cross-sectoral scientists who can make a difference in child health and well-being in Canada. So our goal is to create seamless pathways for learners such as you, many of you in the room, to become influential leaders in every sector that's going to service children and youth in Canada and beyond. That's what I'm here to represent. So if you have questions about Enrich, I'm happy to answer after this. Thank you so much.
question, then maybe then we can have the other panelists come to the front so we can have a few minutes before 2:55. So any questions for Susan? Go ahead.
I really love the framework about creating a inclusive research environment. I think something that's so nice in this work is the environment within which the research is taking place. So I'm just wondering if you can share some best practices that you've implemented in your program to enhance that.
Sure, thank you for asking that. I think one of the best practices that I don't know if I implemented or I as a researcher attract, I have a very diverse research team. There are people from, I shared my love about Nigeria with the team earlier. We have a researcher from Nigeria. We have a researcher from Guyana. We have a researcher who is, or one of my program managers who's an American Canadian. So every culture or ways of knowing is somehow represented, and we actually allow for open discussion. In our team, we allow people to be different. So one individual who is Indian is my lead PhD student in my lab. She said, well, Susan, my last supervisor was quite surprised why I didn't drink. And that was quite hard for her because her supervisor didn't accept her culture. So you have to foster that embracing of differences, that you're accepted just as you are. And that's something that I started in my team, and that gives us so much empathy for the communities that we are trying to study.
Thank you so much. Okay, maybe our three speakers can come up to the hot seats, the three of them. And I just want to be respectful because Melissa's on clinical service now, so she may have to sneak out. And we all have refreshments before the last session. So, so why don't, so when you ask a question, you can ask it to a particular individual or the whole panel can answer. So wondered if I can open it up by asking, just bringing it back to the concept of this conference, which is really thinking around the pandemic and how has the pandemic impacted your ability or a process by which to ensure we have equitable sampling? I wonder if you could think about the pandemic and equitable sampling and what that's meant in your work.
Yeah. Thanks. That's a very important question. And I have had the experience of completing a study that will end up in the Journal of Underpowered Studies, simply because we got the funding right before the pandemic, and we started enrolling people, and the pandemic set in, and we couldn't collect the data as well as we could. So we're looking at the factors that would improve initiation of treatment, adherence to care, and retention in care for people living with HIV. And during the pandemic, the health workers were extremely busy, so we couldn't recruit them. And the plan was for health workers to help us recruit patients, but patients were now having remote care, so there were no patients to recruit. So it became extremely challenging to recruit patients from the community because people were not congregating. So we switched our recruitment strategy to Twitter and using peer recruiters. So we had 2 peer recruiters who were people living with HIV who knew other people who were living with HIV, and we did a sort of snowball sampling approach. So if you find one more person living with HIV, you invite them to the study, and then they can invite somebody else, and that's how we were able to reach a few people, but we still didn't reach the numbers that we wanted. So it turns out the pandemic was ideal to study the pandemic, because the people with COVID were everywhere, right? But other conditions were affected. But my take-home message was electronic sampling and using peers in an electronic space helped a lot. But community outreach and physically going to places was extremely challenging for them.
To be very flexible.
Yeah.
Yeah, I we had to transition one of our interview studies, which was in person, to online. And I found that was really beneficial in terms of recruiting youth who could advise us. We have the Children's Council here at Sick Kids, and they went to online meetings and they got accustomed to that format. And that overall was a benefit because a lot of youth with disability or who were immunocompromised who wouldn't have been participating in our study before if it was in person were now able to participate. So that's one good thing that came out of it.
Some real strengths and benefits.
Yeah.
I agree with both points. That's what happened to our study as well. It made it easier for some, and in particular youth, because they embraced the COVID world initially until the isolation became too much. But we were able to engage them. And actually, I should say the intervention was much easier. Even before COVID, we had thought about virtual delivery of components of the intervention because of the remote dwellers, but it just made it even more accessible. And so there were a lot of advantages. But then, you know, when you have language difficulties, cultural nuances, those people became even more remote. And that became an insurmountable barrier to recruit them into the study.
Let me open it up to the floor. Questions that you have for our panelists? Go ahead.
Well, as you mentioned, actually, I think everyone agreed to this a little bit, but the fact that, you know, having equitable participation in research and that from a research sample perspective is expensive. And often that burden seems to be on the research team. I'm wondering whether or not you guys can comment on what you think the institutions should be doing, potentially that we work in, to help lessen that burden and put systems in place to promote equity in research sampling for the research that we did.
Maybe we'll start with Susan.
Oh, sure. For us, I think a prioritization of research, the different levels of value given to research, depending on who you talk to in a hospital, for example. So there are clinicians who don't really believe in what you're doing, and then there are patients with varying levels of understanding of what you're doing. A lot of what we do in Calgary is try to transform, say, I know you might have already arrived here at Sick Kids in that it's a research hospital. Everyone needs to should contribute if they can. It's an institutional culture that we are trying to change. But then for the hard to reach families, I don't know if I'm using the right term, we need more time, because we need time in the clinical setup, because parking meter is running, you know, they're looking at the clock. So I like this kind of, we'll just get the consent to contact and we'll call you back. But sometimes when you call back, that person is never there, especially youth. So I think we have to allow space for these things to happen in a clinical setting if we're really serious about this. But I know there's so many variables involved. I have no solutions. I have only ideas.
Yeah, I think, you know, something that I'm really proud of what Sick Kids has done actually is our EDI strategy and how much rollout there's been around that. And T. Garnett is our EDI lead, and basically, like, with their advice, with their input, their representation at this hospital has really increased people's ability to talk about these issues, first of all, but also for our patients and families. Like T's office has gotten a huge amount of requests and patients and families wanting to be more engaged and being more interested. And I think for them, especially seeing that there is someone who represents them and their interests, I think has been really valuable. And I think that overall can also kind of help to show this, because you can imagine, you know, if we were saying equity, but without that representation at our hospital level, I think it would be, you know, less conducive to a trustworthy relationship.
Question. You want to make a comment?
Yes. So I have two responses for your question. The first is, it's not your money. So by that, I mean, put it in the budget. Let CIHR or whoever is funding the project fund that extra effort. And with regards to what institutions can do, I know that there are efforts underway because I sit on the Ontario Hospitals Association Anti-Racism Task Force. And their inability to provide appropriate care for diverse populations or to recruit them in research is one of their priorities. And we're currently developing strategies to do this. I don't know what the end game will look like, but there's a solution in the pipeline.
It has to be a metric, otherwise, if you're not counting it, you're not going to count.
Yes,
I'm
grown-ups
going to
and
go to our
numbers.
final question from the front row.
I have a question for Melissa. So you mentioned that you are using artificial intelligence and a machine learning approach to do this clinical work. I just wonder, how can you ensure, because machine learning approach is a largely data-driven approach, so how can you ensure the equity in the data itself, the data you use is diverse enough?
Yeah, that's a good question. And I think of AI as one component within a larger constellation of practices and factors that together promote good patient care. So we might get better at diagnosis, which is a task that an AI system can assist with and can help a clinician to do in a way that might result in less patients being missed, or helping with a busy service, or other different ways like that. But it also can be a wedge for getting other EDI-based implementation strategies around it. So even the knowledge to a clinician that this prediction, some of the uncertainty around this prediction might be related to the fact that this patient is from a disadvantaged socioeconomic background. That can also be linked to other factors like help from social work or our patient navigators, and other supports that family could have. So I tend to think about this being just one piece of a bigger picture of things that together can improve patient care.
So with that, I wanted to thank our speakers for an amazing session this afternoon. And